Enough time to eat lunch to spare.
So scarf something down, at least we can talk stuff. About 6 minutes, a mob will show up and take all the food.
I've attended some of these other parts Zoom, but not in person before. It was back the first time I've been in this building. I mean,
There you go. There you
is
go.
MSOP? Yeah, nice to see you. Nice to see you. It's been, well, I was just asking, is there still an office in MSOB, or how is there a division there with Newsom and it's different?
No, we got pushed out all over here, that old space in MSOB, it's still there and it's empty right now. Sometimes I go there when I just need a place to sit, just go in there, it's like a ghost town. Because that building is due to be demolished. It's actually been due to be demolished for like 10 years. They just never actually did it.
Really? You're gonna cut down the tree. And that building was new when we started in the 80s, remember?
Well, the
Were there
building,
trailers before the building?
the building that I got my degree in is now a pond.
Well, yeah, you should talk about that in often in the intro while people are like settling down and get their foods and down for the first maybe 4 minutes. I was like, especially in your case, oh, Dr. Rutledge, tell us more about yourself.
You go
Where
back
did
to
you
the
grow up?
temporary.
You have quite a history at
No, I think
Stanford.
just after they moved from the temporaries into MSOB.
Okay,
And Ted got the big grant, they kind of forced the university to do
Okay.
something.
it's real. So how you been?
Great.
Am I right? Okay, this is what large language models are good for. You think about your data set.
We're doing something different, you know, we'll talk about it, but we're doing something I haven't seen anybody else trying to use large language models in a manner that leverages the knowledge without depending on it.
Yeah, but the big thing you have that nobody else has is almost a curated data set. See, when I got my start with health docs, we collected our own data. There were no databases. So we would collect, we got 400 patients, that's a large data set. But because they were very carefully selected data sets with good quality data, we could see very subtle things, like we could
What about it?
recognize when chest pain was caused by coronary disease based on where it hurt and how long it hurt, those sorts of things. You can't see that.
I do,
These
I
natural
try to get
data sets are
videos on
really
them, post
used.
them online.
If you think about your data set,
It's actually
you guys have
very,
been accumulating, how long is
real
that?
things to consider. Adding a new trick is often done.
So,
that I
14
won't
years,
ever
you
find
started
anyone.
14
And the
years,
performance
still-
aspect of it.
Yeah, no, you
Actually
must have,
being a lot of items.
you do have a billion encounters.
Usually a very long time to add a new trick that's worth
There's
adding.
different kinds of encounters.
Yeah, but the basic.
It's actually a new trick, but it's not performed very well. It's actually,
Sometimes.
they're not very
I
good.
only have 3 million answers written by doctors.
It's still a very pretty large data set.
Anybody has a larger one.
No, and it's
astonishing.
One of the questions
and
we
it's a high quality
Run
data
a new
set.
app.
Every question asked
Or a new
under the
routine
sun has
or
been
something like
asked,
that.
and typically multiple times for the common ones. We have lots of answers. So you'll see some of the data I'll show have to do with leveraging that question answer data set, because the first thing I did looking at large language models is how well can they do it compared to our doctors. I've got this big database of what doctors have actually done, and then I had put together a panel of doctors, we have
Jansen,
a panel of
right?
doctors to review and compare the contrast between the doctor's answers and the AI answers, and getting the
I think they were paying some
consensus
triple
from
what I got paid,
doctors,
so.
but which answer is better.
It's a rational decision. At some
So
point.
we see when this, this will be 25 and 22, which is when the first ChatGPT first came out. I was unaware of it when I'm teaching my course in January in winter quarter. And I had given this final exam and I had these really sharp students who had done just great. And they were from the computer science side of the, usually I get medical students in computer science class. And these are computer science guys.
Which course is this?
This is mathematical models of medical decisions. And they did very well in the course. They really understood good problem sets, good response like this.
No.
And the final is open book. I say you can use anything you want other than a person. And so these guys get these answers
Many.
and they were very well
Dogs and
written.
grad
They were
students
crap,
have
they were wrong.
race
They
here,
almost
so.
failed the course.
I try to always make that part of the discussion.
And you realize that they had tried to
Why
answer
did you go to university, you go to industry, why
this
did you do
great
that?
big giant
That's
search
a
engine,
choice a lot of
which
people
is
have to make.
large language models really are. Couldn't find answers on the internet because the internet doesn't really understand this something.
Environment, money is definitely a significant factor.
So the idea of
More like
a
more resources,
high quality data
where you have more latitude
foundation
to work in the
is
environment.
I would push back on the idea. The current largest
Do you
foundation.
want to teach training or do you
No,
not?
the answer. I'm astonished
Very different.
at the level of detail, and I published, if you look, and Chuck Friedman concurs me to publish in one of the analysis.
More freedom, I would say, in
The
academia.
ability of large language models to make inferences and to identify.
I've heard others argue,
something there
you have no
unusual.
more freedom, we have no resources, so do you really have freedom?
This is a
You can work with anything you want, but you can afford to
You have a gamble
pay for, it. but
represented by density function.
you're in industry science, if you actually have unlimited resources or a lot more
You
resources.
take the
So in some way
utility,
you're free
expected
to,
utility
I don't
using
know,
the
are you free to
distribution,
train a,
or you take the utility.
fifth generation
of
foundation model?
expected value.
can't do that, there's no way we have enough engineering or like compute resources to do that.
Yeah, exactly.
The area.
Literally like $500 million probably.
Symbolic
Like,
representations of
only if you work
features.
at a.
Yeah.
Combined,
And
and
how
then
much
we determine it's pattern matching.
Yeah.
You're talking something very different. It is
It's all false dichotomy,
inference
it's
involving
things people can do in different settings.
understanding the relative balance of things in nuance and in a different way. The distributions matter,
Working.
and it's unbelievably bad at that. The thing that really.
More stabilization now than we were 2 years ago, back when you were
Asking
here.
it how to solve complex problems.
And more grad students back when you were now,
How
still
can you
do
tell
now,
whether
but
this
now
is
I have
actually
3 postdocs and a couple of clinical fellows, so
Fine.
now that's
Here's-
more
here's an
consistent
experiment. How
base
can
of
you tell
regular
what the
people, kind of like I
difference
just
in
passed the job at my year round.
Calculate.
Now I have kind of like 3
It
people
was
at that
astonishing. It
level.
went through the most accurate description. It gave you exactly the
The
right
thing, we have
answer.
one person,
This
that one person
knowledge,
leaves the industry, it's like it's
statistical
very
was phenomenal.
disruptive, right?
And it
All
gave me the
the
correct,
all work there
formula,
stops,
and
and
then
it takes many months to
For
get.
the, all the
back
data
on
that
it.
gives me, it gave me the answer that was
Now, with a
completely
few
wrong.
people,
Even though the
somebody
formula
that
was
just
completely
does
right,
that,
they give you
but,
the right formula, and all its values for the parameters of the formula are in these statements, like they have to make it up, all there. And they got the right formula, and then they couldn't fill it out.
Including
Yeah,
myself.
because it doesn't, you know how it works, right?
But it's amazingly powerful. So my daughter finished her dissertation at MIT and she ended up like everybody else, being a quantitative biologist. She had to do a lot of programming. I couldn't get her to take the programming
Outside the site.
home. No, Dad, I don't want to be like you, sort of person. And so she takes this course and then has to learn program. And so she had to write a lot of code. She says roughly half of her code study would generate ChatGPT. Never gives something compilable, but it would, you'd give her a problem, you would give her a set of code, and then she'd get this to be on her way. So yeah, it is.
I can use this. Here's a problem, I'm gonna solve this problem in whatever language. It'll give you a framework, and even though the code is given may not work,
Yeah.
it tells you how to do it. Oh shit, I never thought of it that way. Or I didn't know that feature existed, or hadn't thought about doing it that way. And then the answer is like, okay, it worked.
So when I went to, when they made me a manager at HP, they took me with compilers, and that was last century. And so for years, my programming language was functions in Excel.
Yes.
And you can do amazing, I wrote a Monte Carlo simulator in Excel, think about that. And finally got the
Programs in.
yeah, it was like building a scale model of Eiffel Tower and Shakespeare. And so I had to code last year, I drug out a SQL. Now I'm trying to say code.
Yeah.
It's kind of fun.
It will be, I mean.
My daughter keeps saying, Dad, give me a ChatGPT, and give me the answer.
That's the other extreme. Dissertation. I did.
What they're actually doing, so to went some little junior, blah, blah, blah.
That's amazing.
Yeah.
You haven't done
This is
that.
Malcolm, former.
There was a lunchtime meeting.
Former BMI or
It integrates.
BMI student,
Yeah.
right?
I can't find the answer. It doesn't.
Yeah, of course, unless.
And implementation scientist, did a lot of work together.
Yeah, when I took, when I was at HP,
Yeah.
we took a 1 week scheme course for the dialect. And that's one of the things we did develop a symbolic integrator. Yeah, but it's pretty good.
What are we gonna play,
You know what, I asked my husband, I'm like, we were gonna go play pickleball.
Oh,
And he's like, we should just go Monday after.
Level two, I would say we'll start with the informal part about 60 seconds, where we're just gonna like chat a little bit, tell us about yourself, Jeff. What's your life story kind of thing, that'll like 5-10 times, 30 minutes. By the way, we're also being recorded right now, for the entire
And
conversation.
it is,
We'll file in and then we'll
it's,
formally
the
start
courts are
maybe
smaller, and so it's easier on your knees and.
whenever you're ready to go, and then you can kind of take it away from there. That'll be good. Many years.
Let's just say that's my first
Well, it's
time.
not.
Yeah, it'll be fun. Do you have any video or audio or is this like gonna be some slides?
Jeff was ahead of
Okay,
me.
I'll ask him, I'll let you.
I think you'll spawn a lot of good discussion. That'll be fun as well. We got many people. I saw Peter Zolovitz. There's all sorts of people online who came from, I'm sure just.
So is it just like a?
So they surf down, whatever the last bites are, and then when you're ready.
It's like a squirt, it's like paddleball, have you ever played? Yeah, it's more like
Is there a
paddleball,
mic
there's
or
no.
how we're picking up
Yeah,
the sound?
That thing is a microphone.
Yeah, so no
So it's
balls.
actually recording us already, and that camera is what people online see.
Really fun.
My dad goes to
Or whatever this thing is.
Oh, really?
in 1989.
Really?
Wow, by 1 hour.
It's like-
Whatever it is.
Yeah, oh, I know. It's taking over the tennis courts. We moved on to a little local.
Oh, we even have this.
tennis court, so we can fly it over.
Very good. All right, well, welcome everybody. As people are grabbing their food and piling in, we'll let them do that. I want to use some good time to get to know a little better. Actually, our esteemed alumni graduated from Stanford in, maybe we won't say, we won't have to say, okay, at some time in their past. Let's not be too specific
Last
here.
millennium, yeah.
It's very privileged to have Dr. Jeff Rutledge here, who I know you've been very engaged, we attended many times, very engaged discussions. Like, you know what, Jeff? Just get up here and let's hear from you directly, because I know you have so much to share and teach us. But before we dive into that, just tell us more just about yourself. Where did you grow up? How'd you arrive where you are? And I think we learn a lot just about your life, let alone your science.
Well, I don't know about that, but I will share the journey and how I leveraged the PhD work I did here in the section of medical informatics. I did start back in the day with old timers. In fact, I mean,
You just got called out.
when we
Mike.
got,
You see
when we
that?
got started, I mean, expert systems were still a thing, and Bayesian networks were like the new thing. Put together my own dissertation work, involved quantitative physiologic modeling, mixing with symbolic reasoning and Bayesian networks. But that was a long time ago in a different era, before the current era of AI. But I'm a physician. I trained in both in internal medicine, practiced emergency medicine, actually taught here at Stanford in clinical medicine before I started the PhD. And I've continued to practice on at least a part-time basis, as we'll talk about. On my expertise, I would like to say, I hope it's still medical AI in its new iteration. We'll talk about some of that today. I also have become expert in, it's like social networking for doctors. How do you engage doctors in sharing their knowledge in a way that they find fulfilling? And I've had quite a bit of success in building networks of doctors sharing their knowledge and building knowledge bases of information coming from doctors in practice. The network currently at HealthTap has almost 100,000 doctors who are US licensed clinicians who participate and share their knowledge and interact with each
Did
other.
you say 100,000?
US doctors, US licensed doctors.
How many of your doctors are there? I thought there's only 200,000 doctors.
No, there's 1 million doctors in total. There's maybe not all, because you have an MD, even if you got licensed, it doesn't mean that you're an active clinician. There's on the order of 500,000 or 600,000 practicing doctors, and on the order of 200,000, between 200,000 and 300,000, I think, maybe someone has a better number, of primary care doctors in practice in America. Also, the number of FTEs is different than the count of doctors, because a lot of doctors have part-time practices. I'll mention, as Jonathan asked, that, previously I had an academic and teaching career. I was on faculty here at Stanford, and after the PhD, I went to Harvard at Beth Israel and actually achieved a career development award. I spent several years pursuing or continuing the research I'd done here at Stanford before realizing there was an opportunity to have a bigger impact in the corporate world, in the commercial world. And I joined a startup, a fledgling startup that was called Healthion. Jim Clark's company. It subsequently turned into a company probably better known as WebMD. I had the privilege there of building the first consumer health website. This is in the late 80s, we're talking. So in the late 80s, that was when I finished my dissertation. It was the late 90s. I think I started there in 97, 98. We launched the first consumer health site. And I ended up, kind of funny, being as an academic doc with a PhD, joining a startup. I found myself as the vice president of business development doing business deals. And that was an interesting experience demonstrating that you can learn on the job how to do these things. But I left academia to try and have an impact using technology to make healthcare better. That's been the goal all along. As a real clinician who actually sees patients, who understands the technology. How can you use the technology and apply it in a way that makes healthcare better? And to do that at scale, you need to be in industry. I joined a startup which demonstrated that you could reach a lot of people. I did a gig as a consultant and a hospital executive at the CMIO at San Mateo Medical Center, installing health information systems. But my real love as an entrepreneur is to figure out new ways to use technology to make healthcare better. So after stints at Hippocrates, where I was head of development and chief medical officer, demonstrating that doctors would use mobile devices at the point of care. I thought, gosh, we ought to build a system that lets you deliver healthcare on mobile devices. So we started Health Tap 14 years ago now with this idea of bringing care to mobile devices. At the time, there wasn't even a video codec that was usable on video on mobile devices. So we started on the web. I quickly added the mobile capabilities, delivering our first video virtual consultation service. It was about 2012, 2013 when we started the video service. So we were one of the pioneers in the space.
But the first 2 years were basically email exchanges. It was a dialogue.
In the first couple of years, we built a web service, invited doctors to join us. We made a service that allowed people to ask questions. So we had a free online consumer health question service where the question was in text, and we limited it because we weren't paying the doctors. People said we're out of our minds to ask doctors to answer real questions from patients without paying them. But you know, we have 3 million answers written by doctors, which I think proves that doctors are willing to help people without getting paid for it. And I'm very proud of that accomplishment, actually. It's still available online. You could ask a question. When you ask a question, the first thing we do is look to see that someone else already asked that question. There's already several answers to it, so you don't have to wait. If you have a totally brand new question, or if you want to resubmit the question, then you have to wait. It's usually a few hours before a doctor will answer a question. But the journey in virtual care for me, not to go too far off the line, but the journey in virtual care for me was the discovery of how much can be done when you have a high resolution video interaction between a patient and a doctor. When I started, I thought virtual care would be a complement to office-based care. And you kind of needed to meet and know your patient before you could be effective through the virtual channel. What I discovered to my surprise was that you can meet someone virtually and build a relationship with them, and that relationship is oftentimes stronger than what happens in the office. The counterintuitive thing with a virtual consultation is that the only thing you have is the video. In the real world, there's a surprising number of distractions for the doctor in the office. Not only the computer on a different desk, but also the noise in the hall and that patient in the next room. All sorts of things get in the way. Anyway, so I should get to the point.
No, I mean, the other one, of course, is time in the office.
You don't have a lot of time. And what doctors are faced with in the world of corporate primary care, doctors are faced with the reality of they have a requirement to see a lot of patients. Primary care consultations do not pay very much. In order to maintain and manage the overhead and the doctor's salary and all the staff, you have to see a lot of patients each hour. And the inability of doctors to spend time with their patients, and the incentives for them to refer to other more specialty care, more expensive testing is huge and impossible for doctors to avoid. It's actually a source of moral injury to doctors, but that's a talk for another time. Actually, I address that, and I have a newsletter I do every week for the doctors in the network, and I addressed that issue just last week, this notion of what's causing burnout and so on. Let's talk about today, which is what I want to talk about today was the use and the opportunity for large language models and other AI-driven solutions to improve processes of care. What I'm going to suggest today is that in this particular case in America right now, primary care is undervalued and underused, and it's incredibly important. It's actually a source of inefficiency and higher cost. The fact that we don't have easy access to good primary care. And it turns out that large language models can help. I'll start by showing how the language models by themselves are very good at answering health questions that people ask. I'm going to suggest, and they're also very good at generating a differential diagnosis if you give it a set of features. But surprisingly, this is something we're doing now that I think is leading. I haven't seen anyone else do this, which is asking a large language model to conduct a patient interview as if it was a doctor. I'll show you some results of doing that because it's live on our product today. The reality is that the large language model can take a history, write a note, and construct a differential before you even see the doctor. What we're going to see, of course, is more interesting and more extensive uses of this AI methodology in support of care. And the interesting thing is that when the care is delivered virtually, it's easier to integrate the AI into the flow because you can see all of the data on both sides. There are all sorts of interesting applications of large language models driven AI in healthcare. Let's talk about some of those. And I started by commenting how important primary care is. It turns out there's a huge literature showing that if you have a relationship with the doctor you trust, an ongoing relationship with a primary care doctor, your outcomes are better. You live longer. You can count the number of extra days you live for every visit you have with a primary care doctor. You also, and you can measure that by higher rates of preventive care and so on. It also measured that the total cost of care goes down when you have a primary care doctor. Depending on how sick you are, what your risk of illness is, the decrease in healthcare costs associated with each primary care visit is in the order of a couple of $100 when you're young and relatively healthy. It's like tens of thousands of dollars per visit if you're sick. If you were just discharged from the hospital with heart failure, you're at home now, each primary care visit has an effect of reducing your total cost of care by tens of thousands of dollars. Remarkable. So, and the problem now is we don't have enough primary care. We're not incentivizing it. It's really hard to be. Primary care doctors are burning out. We have too few of them. And it's really hard to get care. Many people in some areas of the country, there simply isn't any primary care. They're deserts for primary care. In other places, even when there are doctors around, the time it takes to get in to see the doctor prevents them from being as effective as they should be. Lots of people don't have convenient, accessible primary care. And the reality is that the virtual platform makes it easier to distribute the resources of primary care doctors. It also supports the primary care doctors because it gives them a job that they enjoy doing. They can spend more time connecting with their patients. You look skeptical, Mark. The reality is that virtual primary care is effective, it's incredibly efficient, and it makes it possible to distribute primary care to places where otherwise it can't be reached. It makes it more accessible even in places where there is primary care, but doctors aren't immediately available. I want to describe the sequence of experiments that I've done or testing that I've done that correlates with other studies also looking at how can large language models be used in healthcare. The first thing I did was to ask the question, I've been already been having doctors answer questions from patients for a long time. So I said, well, hang on, how good are the GPT answers to those same questions compared to the answers already given by doctors? This was done with GPT 3.5 when it first came out. I took a random set of questions asked on our sites. These are real questions asked by real people on HealthTap, were already answered by real doctors. And then I got the GPT answer and I took a panel of doctors. I had a bunch of doctors for each question answer pair say, how good is it? I wasn't comparing one answer with another. I was saying, for each answer, how good is it?
What's the end on this?
There were, the question was in the hundreds of.
That's what
So for each question, there was an answer from GPT and an answer from the doctor. I had a panel of doctors give assessments, and as I've discovered in previous work, when you ask doctors what they think, there's a wide range of opinions. Somebody would think it's great, somebody would think it's terrible, but if you have enough doctors give the answer, the median, the consensus among the doctors is actually a very accurate measure of what's really going on. So what this shows is that when you look at how doctors evaluated doctors' answers versus how doctors evaluated ChatGPT answers, you see the assessment option for each answer was, it's wrong. There's something in it that's just incorrect. So we should recognize that it's making an error and potentially misleading. It also could be correct but incomplete, or it could be a good answer. Or if it's particularly effective and explains itself well, it could be labeled by the doctors as a great answer, not just a.
Was this blind? Was the
Yes,
evaluation blind?
yes, the evaluations were done by text online, saying, here's the question, here's the answer. Tell me what your assessment is, and then they just looked across the board.
Do we know if the model was trained on the same data that you're using?
This was using GPT 3.5, which is modeled on the internet.
And were these
And all
questions
data.
on the internet as well?
The questions essentially all have been available. Yes, it's possible the answers were, the direct answers were there, but the questions were there, but that doesn't mean, who knows what the right answer is? We're comparing the answer the doctor gave with the answer GPT gave.
You mean your answers were available to ChatGPT?
Yeah, who knows, maybe, right?
I don't know they were used,
That's
but they're visible. It's an interesting point, which we'll get to in the next.
Yeah, Jeff, one of the problems I've seen in a lot of these evaluations is there's not a utility factor here, like when it's wrong, how wrong is it? Is it just a little bit wrong or is it, deadly wrong?
That's true. And I didn't investigate that, but I was looking at what is the overall rate at which doctors thought there was something wrong. What astonished me was that the doctors thought there was something wrong with the doctor's answers about as often as they thought there was something wrong with the GPT answers. The more important thing, I think, is if you combine the good plus the great, you see that GPT was giving, in the end, much more often a great answer than the doctors were given. And sometimes you can realize that doctors are going to be short, concise, trying to give just the point. And it's one of the things we've seen with the large language models. They can be more expressive, more thorough. There's no incremental cost in giving a longer answer that's more complete than the doctor, which is just gets to the point and they're done. But the bottom line was it's not worse, and it was not significantly higher rate of incorrect answers in there. And my takeaway from this was that even GPT 3.5 is doing as well or better than the doctors at answering informational questions. And these are not planning questions. These aren't difficult diagnostic dilemmas regarding treatment test strategies. These are just, can you answer an informational question? And for that, it's really good. I then asked the question, well, how about the task of differential diagnosis? How good are the large language models at diagnosing specific cases with known answers and compared with other methods of reaching a diagnosis? Now, looking at what's been published, you see that previous researchers have looked at the ability of GPT-4 and DeepMind to analyze difficult cases. All of the previous stuff I could find, the researchers are looking at published complex cases, typically New England Journal cases, where they extract from cases which, to your point, were actually published in the literature, the ability of the AI to solve those cases. And in virtually every case, GPT-4 anyway has done as well or better, significantly better actually than the physicians and the other comparison groups, indicating that on cases that may have been included in the training set, GPT-4 does better than doctors. But I was very intrigued by this notion of what happens if the cases that it's shown were never in any training set. Those were challenging New England Journal cases. Looking at, there's another set of cases that have been used for evaluating the ability of diagnostic decision systems to give support, the symptom checkers, which were common a little more than 5 years ago. There was a standard set of published cases Semigram did and used for comparison, comparing how Iliad and other AI symptom checkers were doing. So those data were published, and it's easy to, it's the same cases where it turned out that the AI systems were not doing very well at all. But as a byproduct of those studies, they showed how the doctors did on those cases. So I had a set of cases that were published for which we knew the doctor's performance. And I compared the GPT-4 performance with the doctor's performance. And if you ask the question, is the actual diagnosis in the top 3 from the AI, GPT-4 got it right 100% of the time versus the doctors at 84%. If you say, how often is the top diagnosis correct by the doctors in this set of straightforward clinical cases published, you can look at them, and most good doctors looking at them recognize what most of the cases are. But in the study, only 72% of the time was the doctor's first diagnosis, the actual diagnosis, whereas GPT-4 got it right 96% of the time. These are two sets of cases, simple but straightforward clinical cases versus really complicated New England Journal cases. In both situations, the GPT model did better than the doctors. So I asked the question, well, what if these are difficult cases that have never been published? It turns out Chuck Friedman, many of you know, had back 20 odd years ago, created a set of cases. He and Wolf and Elstein created, the three of them called themselves the Trace Amigos. They created a set of difficult cases that were hand curated from known cases with real outcomes, where the cases were incredibly hard. I mean, the answer, the diagnostic answer was not evident, and a lot of possibilities were there for these really challenging cases on difficult medical problems. And so when you looked at that, it turns out that faculty level physicians were able to get the correct answer right in the top 6 about 50% of the time. That's the best doctors looking at these cases. I put them to GPT-4 and found the GPT-4 got the correct answer in the top set of diagnoses 61% of the time, which I found quite remarkable in that it could not have been used in the training set. So this to me shows that really it's real how the large language models are able to detect patterns in cases. When you present the data, they figure stuff out, and they have a large repertoire of possible diagnoses to consider and to put on the differential list. So I took great heart in this, indicating that for the purpose of diagnosis, large language models are surprisingly good.
The caveat here is that you're looking, at least in the Three Amigos situation, at hard, unusual cases
Yes,
that were designed for medical education.
yes.
And it's reminiscent of the evaluation in Internist 1, which goes back a few decades, where Internist 1 did astonishingly well on CDC cases because they were so integrated and so hard, and did miserably on the kind of stuff that walks into your office.
Yeah, except stuff that walks in your office, it gets right 100% of the time. That's the point. It works incredibly well on the common things. And it has a depth of knowledge that allows it to infer in difficult situations with incomplete information what possibilities are to be considered.
Okay.
I've always thought of these tools as in a clinical environment as being helpful memory aids. I mentioned as an aside that in a previous study, I'd looked at what happens to the diagnostic accuracy of doctors if you suggest answers to them. I presented a set of cases to doctors and said, what's the answer? And they gave me the answer. And then randomly, the cases were presented to doctors along with the list. I took the AI generated list of differential diagnoses and I randomized it so it wasn't prioritized. It wasn't, you could just pick the top one. I randomized, but the correct answer was on the list of 10. And I showed the same cases to the same doctors. Each doctor saw a different case, but the same set of cases to doctors with and without the presence of a tickler list, a set of things it might be. And the diagnostic accuracy of the doctors went up 20% by showing them, in other words, they knew the answer, but they weren't thinking of it. When you suggested it to them or made them think about each of the possible things it might be, their diagnostic accuracy went up. So I'm a great believer that providing support in the forms of, I don't know what it is, but you ought to think about these things, is actually incredibly valuable.
I think that was followed up with that radiology study recently, where if you do it too late, everyone's anchored,
Yes.
don't change. Whereas if you present that list with it
Before they've declared the diagnosis, they're more open to thinking about other things. And as they jump to, it's very natural clinically to follow a path. Oh, that might be this. Let me think about that and follow it down. As opposed to at that moment saying, here are all the things to think about to make sure you haven't jumped too early to the diagnosis.
Excuse me, why are am I interpreting this correctly? Why are the sample size for the GPT models so much lower than the physicians in this slide and the previous slide?
Sorry, don't say the question again.
Like, so the sample size is 43 out of 45, but for the GPT it's significantly smaller than for physicians.
The doctor's evaluation as published in literature was many doctors, each of which looked at a subset of the cases. So each case was looked at by multiple doctors, and the aggregate analysis involved multiple doctors looking at all the cases. In the case of the GPT-4, one doctor, which was GPT,
Oh, yes.
one answer. So yes, the statistics are weak, but still as I put the p-value for the comparisons there, showing that there really was a significant difference between GPT and the doctors. It takes a lot of doctors are so variable, you need a lot of them to actually make any broad assessment about how they're doing. So
Go back to the previous slide just for a moment, please, just right there. I see, thank you.
these are data, I should mention, the top line is what I did. How did GPT-4 do? And Chuck was good enough to share these cases with me under the condition that I wouldn't publish them because they've never been published and don't want to be made available in the training set for future large language models. And the other numbers are coming from reports in the literature when those cases were evaluated by previous generation of AI systems. I don't know how many people in the room know about Iliad or even remember QMR. But those were sort of previous AI systems. These studies are from more than 20 years ago in terms of performance of those systems on these cases.
Yeah, so are your hard cases, were they like rare diseases and difficult to diagnose, or were they more subjective, like mental health illnesses or something like that?
They were all hard diseases that ultimately had a correct diagnosis made.
Okay.
But the issue was trying to think of what it might be so you could figure out what tests to do to confirm it, because the clinical presentations were ambiguous and uncertain, and there's no way, I mean, the best doctors looking at them couldn't even get the right answer on a list of 10 possibilities for what that might be. They were that difficult to infer what might be the underlying cause.
When you made up the slide, you must have looked up Ted's comparable study of mice, and I'm just trying to remember the numbers. So they had the same gradation of skill level. And I remember that as being higher numbers than this.
Not on these cases,
These were mice in cases versus these cases.
this is the Tracy Migos cases are unique because of how difficult and ambiguous. They were chosen to be difficult by hand curated to be really difficult cases in internal medicine with definitive answers. But then they withheld the diagnostic information from the cases. So I did say, hey, how do large language models work in healthcare? I just point out there's lots of ways in which large language models are already being used and will be used in the near term versus significantly enhanced functionality in the future. And so we're seeing a lot of applications where they're being used to support and supervise billing and claims and prior authorization processes. It's really good languages. You can use them to write letters to complain. You can imagine the large language model from the doctor is going to argue with the large language model from providers sending back and forth letters.
Already happening.
And it is happening. It's crazy. They're also, in my opinion, very valuable. We haven't done this yet, but we're going to, which is using the language model to present to the doctor a summary of the patient's prior records. Being able to summarize. Now, there are some concerns, and particularly when you have lots of data, that it'll ignore some important things and it may fill in data in other areas. So it needs to be used cautiously because of this ability to make stuff up, confabulate, or hallucinate, as people say. But I still think there's real value because compared to not having, if you give a doctor a gigabyte of data to look at, they're not gonna find all the things that can be found by the AI looking at the same thing and presenting a summary. So the summary is way better than the alternative of asking the doctor to do the review primarily. And I see us at HealthTap doing the same thing, which is the point that we can get electronic records. We should summarize them for the doctor at the point of care, give them a starting point for the conversation with the patient, and support that. I would point out that in the current state we're seeing, and I've got friends who already tell me that the first thing they do when they have a medical issue with their kids or whatever is ask ChatGPT. Because it'll give them answers to their questions and give them suggestions which guide their access to. Some of it can be hazardous if not done right, but smart people can actually use ChatGPT today to figure out what to do for a given medical issue. We're going to see more of that. And so getting an answer and also using it to decide whether or not to engage the doctor. And I would comment that the current implementations of GPT, almost always when you have a health question, end by saying, and you should talk to the doctor. In terms of giving some guidance about how important it is, I think there's a real role for that, and I think it's actually happening endogenously. There's also the possibility, which is the failed model of expert systems, which is to have doctors consult the oracle. Like, I don't know what's going on. Let me ask the question and get some guidance. There may be roles for that. It traditionally has been challenging to get doctors to spend time consulting an oracle to figure out what's going on versus simply referring the patient to the specialist who will figure out what's going on. We are seeing a lot in just about every major EHR vendor now is built in ambient listening capabilities where you're having the LLM listen to the audio, do the transcription, and then generate a note for the doctor. There's some concerns there also that the AI is not yet well able to pick out the wheat from the chaff, figure out the important parts of the conversation, and then organize it the way the doctor would. In some cases, it's been shown that the documentation may include things that weren't actually said during the conversation for the same reasons. So there's some issues there, but I just comment it's actually in practice today, it's currently improving support, and the feedback I hear is the doctors actually like it. They like having a note written for them. But I would point out that when you do that, it doesn't change the care delivered. It reduces the time taken by the doctor to document the care. Maybe it'll be used for creating differential diagnoses and decision points for the doctor to think about, but fundamentally doesn't change the questions the doctor asks and doesn't suggest new options the doctor didn't think of, and only respond to the data acquired from the doctor. I'm going to describe now in the final section here this notion of using the large language model in the role of the physician assistant. You may know in many environments, the physician assistant will do an initial interview with the patient, try and figure out what's going on, maybe solve the problem, and tell the doctor they don't need to see the patient because they figured it out and they treated the patient, and the doctor signs off on that. They may also say, here's what I found and I can't figure it out, or it's complicated and let me give you the history that I've acquired so far, and you take it from here. That's the model we're using in HealthTap, which is to ask the large language model to conduct the interview, thinking of the questions to ask the patient, collecting the information and writing the note. Secondarily, as a result of collecting that information, the AI has an opinion about the differential diagnosis.
This is the role of the medical student in the team.
Just like, and if you let a medical student that doesn't know very much do it, what's the harm in letting an AI do it? The medical student got it wrong because they didn't ask the right questions. We don't think of that as a hazard to the patient care.
However, they did learn because they were no longer being used.
Well, my presumption here was that even if it didn't ask the right questions and didn't give information useful to the doctor, that it wouldn't cause harm.
But you know, it's a different expectation when you're dealing with a medical student. You know the limitations of the medical student versus.
Which is why we highlight to the doctors, they need to confirm the possible diagnoses and
Oh, yeah, of
recognize
course,
that there may be great gaps in what's there. But the astonishing thing is how well it actually.
I also think there's an important component, if the medical students aren't doing it anymore, where are they getting their training, right? And so how do you incorporate
I
that?
think they'll get trained by the LLMs.
I have a daughter.
You can imagine the training system where the medical student takes the history from the LM, asking the question, the LM behaves like the patient instead of behaving like the doctor. So we did this at HealthTap. What we did was we use an API that ensures that we manage the conversation with the patient. If you just go to ChatGPT and ask it the same kind of questions, not only will it give you the answer, it'll tell you what you should be doing and what the next step would be, and it goes on and on trying to be helpful. And you can't do that in a clinical setting where you're providing advice or treatment or recommendations to the patient. We've constrained it, so what it does is it asks the question and listens to the answer. Whatever it says about the answer, we ignore. And we say, but what's the next question you'd ask, given that answer and everything else you know about the patient? So here's just an example. I give a sample actual feedback to give you an idea of how this works. Again, this is live in the HealthTap product. When you schedule a visit, if you use your iPhone to schedule a visit for a primary care doctor, as soon as you schedule the visit, it says, why don't you do the interview? And if you do the interview, it looks at who you are, how old you are, what medical conditions we know you have, and if you're on any medications, and your stated reason for the visit. Like, what's the problem we're trying to solve here? That's the input, the context to GPT-4. And then we say to GPT-4, you're a primary care doctor trying to figure out what's going on. What's the first question you would ask? You listen to the answer. You ignore what it says about the answer, but then you say, okay, given that answer and everything else we already know, I have to restate the context. What's the next question you'd ask? We do this iteratively until it runs out of questions. It says, okay, or we hit I think we have a maximum limit of 20 questions as part of the pre-visit. So here's an example. The context is a 69-year-old male with mild hypertension on lisinopril, and he says, I'm quote, having trouble sleeping through the night, getting up too many times. That's the reason. And then engages in a conversation. You can see when it starts, hello, it's always sympathetic and understanding and so on. I understand you're having trouble sleeping through the night and you're waking up multiple times. Let's gather some more information to help your doctor understand your situation better. So the context does, it's explaining to the patient that the reason to engage is to help. You're going to see the doctor, but we want to help the doctor take better care of you. And the language model is surprisingly good at expressing that to the patient. Can you describe the nature of your sleep disturbance? For example, you have difficulty falling asleep, staying asleep, or do you wake up too early in the morning? So the AI knew the context of sleep difficulty, what the key features of sleep disturbance are to be elicited from the patient. I've left out along these interactions have many questions and answers, but I was curious to see, have you noticed, he says he's having sleep disturbance. The language model says, have you noticed any changes in your urinary habits? The language model knows that prostate problems causing urinary habit problems can lead to getting up at night and having trouble with sleep.
But does,
No, it doesn't know that. It knows
Knowledge is the wrong thing. The problem is these emergent behaviors can't be described in words that we're used to, right? This is an emergent, in my opinion, this is an emergent behavior large language model, doing things that we wouldn't expect it to do, that we infer are related to its understanding.
describe. Yeah. Yeah.
But did it have access to the patient's PSA? In other words, is there a context for it to populate the set of questions? The set of questions are great, doesn't it? But does it have a context? Does it, for example, know whether or not this patient has elevated PSA levels?
In this case, absolutely not. The entire context is in the first line.
I see.
In this case, when many people come on virtual care and health tab, this is the first encounter with us and we don't have any prior records. And so it's a demonstration of what can be done with minimum context.
Is that summary made by the physician, the 69-year-old history of mild hypertension, or
No,
is that
that's
generated
that's
some way?
they have the data point is the context of the question to the AI to GPT-4 is age, gender, naming a condition, naming a medication. It's not word, it's not text, it's not a paragraph. It's just we have structured data that exists on the patient. We provide it in structured format, but it's essentially the same information. So what happens after that? Well, here's the actual summary generated by the AI, which is what was given to the doctor at the time of the actual visit. So this is the note, which can be used as a draft of the SOAP note, the subjective part of the SOAP note the doctor has, which is intended to summarize the answers to the patient's, the questions that were asked the patient in a way that helps the doctor understand what's going on. So on Health Tab, when the doctor sees this patient, the first thing they do is read this, which accomplishes gives them the answers to the first set of questions that would have taken 10 or 15 minutes to ask and give the answers to. And to the extent the questions were reasonable and meaningful and these data are helpful, the doctors will use it. It's been quite interesting to see how the doctors have responded to these draft notes. And there's extremes. In one extreme, the doctor reads it and says, fine, and then writes a much more ignores it, doesn't include it in the final note, writes their own note, which focuses on the thing they care about, and generally is a subset of all this information. Just, 69-year-old with this has BPH treatment recommended, whatever, all over the urologist. Well, other doctors look at this thing and they say, oh, this is fabulous. They read it all and they just use it as their note with minimal or no changes. And finally, there's another model, which is actually the most common, which is the doctor still writes their concise note, but read, review, and agree with, and then they copy the whole note from the AI. So they still get in their own words what they think is going on. When they read it, they can, in a concise way, reviewing their own notes, know what they were thinking at the time. But meanwhile, they've documented the answers to all the other questions that needed to be asked, which were found in the AI summary.
Okay, so you've mentioned this several times, we kind of brush it aside. The one flaw of this technology is its ability to hallucinate. For example, that last paragraph there is pretty important. And how often does it put in that report? And furthermore, the patient reports lower back pain or blood in the urine. In other words, how real is that problem?
So would you expect that to happen in this use case? And the answer is no. The reason is the data that it is trying to summarize, it's being asked very specifically to rephrase what the patient said. The patient said what they said. And there's no context for it to make something up. There's no blanks to fill in. The making stuff up generally occurs, as I understand it, and how the AI is making a pattern, making a picture, and it has holes. They fill in the holes with things that would be reasonable.
It reduces it. I mean, it goes from 20% to 5% or 4% or something like that, but it's not, you can't, there's no way to remove it. It's a nature, it's not a bug, right? It's a way they work.
Yes, I suggest that in the presence of a small undefined set, you're asking it to restate that. The chances of that happening.
It's lower.
It's a really good point. It needs to be studied and confirmed. We are in the process of reviewing manually the complete set of the dialogues versus the whatever, so we should have an answer to that.
You need to begin for that one to be credible.
Well, but it happens less than 1% of the time. We have to do a few hundred.
But also, again, the utility side of it is also important. I think not just the, their end of the curve is not good enough. I think in the clinical setting, that's also the impact of the missing data. So I was just going to ask you about, I guess, I don't know, about the FDA situation, but I guess it doesn't really matter since the FDA is probably not going to be here in a few months. So it might not be a problem for you.
The key thing here is, and the reason we get around software as a medical device and so on, is that there's nothing we're doing here that even suggests a course of action. The only thing we're doing is presenting information about the patient, and I don't think under any circumstance that would be viewed as a hazardous thing to do.
But Jeff, that's not true. If the system says there was blood in the urine, what doctor would not follow up on that? What doctor would not investigate that? And you can
It's synthesized.
conceivably,
It's going to be interesting. It's going to be important to document, to your point, that the summaries represent what the patient actually said.
Yeah.
And showing that that happens at high degree, which I believe it does, by the way, is necessary part. Showing that the result of that isn't harmful, I don't think is going to be difficult, because it's information that the doctor uses to create an assessment, and it's only one element. And the doctors are being asked to confirm everything that's important.
so what we don't see in the
Let's
slides.
get another comment, just like says Steve Ash has hand raised for like 5 minutes. Go ahead, Steve.
That's okay, finish your thought and then maybe on the next.
So what we're not seeing in the slide is the information that the patient provided in response to that question, and that's what this summary is constructed from.
Yes, again, purpose of time, the details, but the reality is you look at what the patient said, and that last point about expressed possibility, inferring from the way the conversation went, what was important about it. Like the patient didn't say in this stream of answers, didn't say, I'm worried about, expressed, it was more indirect and astonishing, but.
I'm a primary care doctor. I love this. I'm sure I'll use it someday, when the FDA doesn't exist anymore. But I am also thinking about, like, how does it actually emulate what I do when I take a history? And there's some things that are missing, and I don't know that it'll ever get there, without, video and audio, rather than text. And one of them is, I know when the patient looks like they're really concerned and looks like they're not. There are many ways the patient could have expressed a concern about possibly having undiagnosed prostate cancer. He could have said it offhandedly, or he could say, my brother had undiagnosed prostate cancer. That's the reason I'm here. And I feel it, I see it. And it gets back, I think, to the utility issue that you were talking about. Each one of these answers has a either utility function, or I will go a little bit further and say, as a physician, I am more or less certain, or it has more or less import beyond what the text itself says.
Sure. But again, the key thing here is that we're trying to set the doctor up to make all those very determinations. Now, I agree. I think actually in the future, the AI will look at the video and make assessments about the patient's mental state and how serious and emotional response they have and so on. But right now, the intention here is to provide information for the doctor to guide their evaluation of the patient. And I'm relying on the doctors and talking with the patients to make assessment, because they'll bring these issues up.
But it could, it could be misleading me, for instance, and then I'll be quiet and let you get to your next slide, which you've been trying to do for about half an hour. Is in the end, it could be misleadingly, patient expressed a concern about possibly having undiagnosed prostate cancer. It's not the first thing I think of in this situation, though it is one of the things I would think of in this situation. Now I'm really gonna think of it, right?
But the reason I think it's there is that it gives the doctor an opportunity to address the concern in a way that be meaningful to the patient. Because they can, hey, is this, I understand you may have been
But
worried about
it may
that.
be actually wasting my time instead of doing so.
Because we don't know how that item was elicited. Or at least in the summary, and we don't know whether the program said, you're worried about prostate cancer, aren't you?
Yeah.
I mean, there's a lot of subtlety that's.
Yeah, I mean,
And they, if I may, the challenge of figuring out how good is a doctor interview is, the problem is the scope of what they could have asked versus what they did.
Sure.
And there've been various constructs to try and evaluate the effectiveness of a medical interview. But, just because the answer to a question was no, doesn't mean it was a bad question to ask. And so at what point do you know how many pertinent negatives you should pursue, and is it relevant, and how? It's really, in my opinion, complicated because of so many things that you could ask about, so many potential things that are potentially on the differential on the utility function of the time and cost of asking the question is not an obvious.
I mean, blood in the urine is gonna subject that patient to a very unpleasant procedure.
But he hasn't had blood in the urine. He says he.
Yeah, I know. Yeah, it's just the utility of this information is pretty important. It's not simply a hint.
Yes. But the expectation again is that when something is important, the doctor will address it, not take it at face value. The whole point of this is like when the medical student says something to you, you kind of confirm it. You talk to the patient to make sure that it's what you think it was. And how often we discover with medical students, sometimes they're so far out in the left field. Interestingly, the response from the doctors to this, by the way, the primary care doctors doing virtual primary care and LTAP, I say, this is just like having a physician assistant take the history for you. And they looked at me, Geoffrey, literally, this doctor said, I've never had a physician assistant that good. That's the blunt response of the doctors looking at these results, because they don't expect the physician assistant to have the knowledge needed to ask the questions that are actually being asked in a given context, which is, in my opinion, emergent behavior. And I'm not seeing anyone else doing this yet. I suspect it will eventually be something that's done, but so how good is it? How do you evaluate how good this is? Did it ask the right questions? I'm sort of at a bit of a loss to how you evaluate it, but just to say, what was the way we've implemented this, I haven't known. My concern would be if I show the differential diagnosis to the doctors, I'm leading the doctors in some direction, different from the actual raw data of the patient. And do I know that the AI is doing a good job and that the right answer will always be there? I don't. So right now, when our first implementations, we got started to generate more data around how well it works. I don't show the doctors the differential. I just show them the note, which repeats what the patient said back to them. Modulus, whatever confabulation occurs, which I don't think is happening, but we are going to measure it. We are going to measure it. And so I haven't shown this, but what that means is the doctors didn't see this, and now I can compare what the AI thought the patient had based only on the AI interview and the context with what the doctor thought actually happened after the doctor actually interacted with the patient, saw their emotional state and how they responded to questions, confirmed things, asked new questions, and using that, admittedly, they used the answers to the previous questions as a starting point, but they had an interaction with the patient and then they put diagnoses on the chart. So I said, well, I don't know how to evaluate whether those were good questions or not, or how to compare them with the questions the doctor asked. But I can look at how good their differential is compared to what the doctor thought the patient had after seeing the patient. And so in terms of how do you evaluate, the first question I asked, of course, was, could this potentially harm patients? I concluded that the risk of that was incredibly low and was willing to actually go out in the commercial service and make it go live in the first step. Of course, we're going to observe. It doesn't help if the patients say, I don't want to talk to that. Right? We don't force patients to go through this. And so one of the observations is, do patients engage? And frankly, it's not the majority of people who choose to do this after scheduling an interview. We don't make them do it, but we tell them that it would help, and the doctor you'll have a better visit with your doctor if you do answer these questions first. And some people ask one or two and then they say, just say stop. And that happens. But the next thing we can ask is it making accurate assessments? Is the information driving the diagnosis? How good is the diagnosis that the AI makes is a measure of whether or not it was asking questions that the doctor thought were relevant, because that's the answer the doctor gave. That's my rationale for comparing the differential diagnosis list. And to the point of, is it helpful? I'm suggesting that if the doctor's answer is on the differential, that's a good thing. It doesn't have to be number one. As I've described before, reminding doctors of things that might be to consider is a useful task. And so how often did the AI have on its differential the answer that the patients had? Interestingly, when you look at these patients, again, this was a random sample of people who chose to do the interview. The doctor put one diagnosis on the chart most often, but sometimes two or three or four or five, or sometimes even the doctor puts 7 diagnoses on the chart. So I had to consider how to evaluate the diagnosis. Should all of those diagnoses be on the chart? Many of the large diagnosis lists are diagnoses that are other things the patient has not relevant to the current problem. Patient with hypertension has a UTI, right? Their visits for a UTI and you diagnose UTI and treat it, you're happy. Also documenting that hypertension may not happen in the AI interview. Whereas the AI, most of the time, put 10 diagnoses on the chart. Said, okay, based on what I know, which may be incomplete, I can think of 10 things that should be considered. And for a lesser number of cases, the AI said, really could only be this or that. Sometimes just one. It's here, I know the answer, this is what it is, and I don't have any other suggestions.
What is the N for the gray bars?
The count is on the left there. These are counts of cases that had this many diagnoses.
So it's like 100 cases.
Something over, it's 124 total cases in this set. This was the first set of cases, the AI.
And so these are individual diagnoses, not like a differential.
So there were 10 diagnoses, like on this list that I showed here. There were 10, this counts 10. So that's one case with 10. So one of the cases of these 65 out of 124 cases had 65 out of 124 cases had 10 diagnoses on the list.
But doesn't this cause you some concern? Because you look at it, why 10? Why not 11? Why not 9? I see there's 112.
Some of them are a little bit more. I restricted it to the first 10.
I see.
Why does the large language model put 12 instead of 10? Why does it put 5 instead of 12? Can't tell you that. This is what GPT was doing. Anyway, so when you did, what I did was I said, all right, if you look at the first diagnosis the doctor put, the first ICD-10 on the chart, how often did that appear anywhere on the list? This is analogous to what we did earlier, looking at is the doctor's right answer found on the differential? Or did the doctor think it was something that was not even contemplated? And the answer was that 88% of the time, the first diagnosis was in the top 10. More often than not, the first diagnosis was also the first diagnosis the doctor made. But in a smaller number of cases, the doctor put a second ICD-10. Well, how often was the second diagnosis the doctor made on the list of things that the AI also said could be? Because it will put multiple diagnoses that correspond to different aspects of the same case. On the same, someone with hypertension and a UTI may have both on the differential if it's aware of both things.
So those ICDs
Stop.
are
We've got
generated.
like 5 minutes to go. We've got 3 questions online, so can you race through to the end? I want to get some time for online questions, and you guys can keep talking to Jeff all day long.
This is the end. This is the only thing I can say about how effective this is, other than the doctors like it and it reduces the amount of time it takes to see a case, is that the differential diagnosis created by the AI appears to align most of the time with the diagnoses that the doctor actually ends up making on the cases. And so in summary, primary care is really important. We need tools to improve the efficiency and effectiveness of primary care doctors. Large language models have a role in improving how doctors work, and I think we're going to see more and more of this over time. And we're going to see large language models get better. We're going to see more automation of routine, particularly for automating routine tasks, but also for doing things that are intellectually, cognitively, and clinically relevant. With that, I can take questions.
Fantastic. Great discussion, Dr. we've got 4 minutes. I'm gonna try to squeeze in some online questions. Matthew, Lynn, do you want to quickly ask your question?
Absolutely. Thank you so much, Doctor, for the presentation. I was thinking about the utility of this, and could you give me a kind of foreshadow about the potential effects that AI utilization would have with patients in the clinic? Because when I'm thinking of trust, I trust a doctor a lot more than ChatGPT, but I also am willing to search up my questions on Google a lot more than I'm willing to go to the doctor. So can you give me a kind of revision for that?
I think GPT will continue to be useful for patients who have more questions about the thing the doctor told them about. And they'll continue to use that to get an expansive idea and understanding of topics that are related. I think also people are going to use it more and more to try and define the questions. There's one last thing I didn't actually mention is one of the other things the AI does, if you ask it, is what are the questions the patient should ask the doctor? We suggest to the patient questions that they could ask for discussion, and that's another role which is important. And it's surprisingly good at identifying questions that would elucidate the distinction and the decisions that the patient needs to make. But ultimately, in my opinion, to your point about the doctor being the trusted entity, all of these tools, in my opinion, are best positioned to give the doctor the information to allow the doctor to have a guide them to doing the right understanding of what's happening with the patient, and then have the conversation with the patient, where it's the doctor conveying the information to do the trust. I guess I sort of said it before, but I'll underscore that point. Virtual primary care is all about a doctor that you know and trust. It's not telemedicine or digital urgent care has a role, but it's not primary care. Primary care is different. Having good primary care means a doctor you know and trust, to your point, that you can actually interact with and then respond to because you trust what the doctor is saying to you. And the astonishing thing is that you can meet the doctor virtually. And on HealthTap, after you've met the doctor, you can send them text messages so you can interact with your doctor to get guidance about whether or not you need to see them. And you can see them repeatedly over time. And even when you need care beyond what can be done in primary care, trusting the doctor to tell you how to go and get what care with what urgency is also an important function of what primary care doctors do.
Wait, Rena Bargava, I know you have more of a comment than a question, so you can do that. You got to keep the 60 seconds or less.
Hey, thanks so much, Jonathan. This is Rena Bargava. And I was medical director at Kaiser Permanente. We built electronic visits, Jeff, with a model that's very similar to yours. And I would say it lends itself to uncomplicated conditions where we put in some strict inclusion criteria. The moment we're talking about stuff like abdominal pain, chest pain, shortness of breath, dizziness, those conditions lend themselves to either a video visit or an office visit and so forth. But simple conditions, whether it be UTI, sinusitis, the list goes on, and primary care is overwhelmed. We do not have the resources to take care of so much stuff. If we can take care of the low-hanging fruit with this model, and I published about that in JAMA as well, made a note there, but I think this is great. Regenerative AI is gonna really help train these LLMs, these models. So RAG, as they call it, will clean it up and really help us hone in on the high-risk patient who should be falling out of this model. Thanks, Jonathan. Thanks, everybody.
Couldn't agree more, by the way, in terms of tuning and focus and parameters around, and using the AI to figure out when the AI won't work is also an important feature. Just to highlight the cases where you really need to say to the doctor, this needs more detailed evaluation.
I think Rena's actually going to come and be one of our guest speakers in the winter, so she'll dive into discuss a little more, use a little bit. Great to have you online. Why don't we give you the last question, and anybody in the room, please reach out to Jeff directly afterwards. Let's go ahead. This online, you're unmuted, can't hear you.
Oh,
His question. Go ahead, Peter.
Now we hear you. Hey, Pete, how are you?
hi, Jeff, thank you, that was great. And I'm really happy you're doing this kind of work, which I think is absolutely essential. But I use worry more than you about hallucinations. And I'm just thinking, for example, of a recent treatment from a school CSF, where they were looking at large language models to summarize, to create discharge summaries from department visits. And their conclusion is that there are actually a lot of made up shortcomings and omissions in those applications.
Yeah, absolutely. I actually addressed that earlier. That was the study we're talking about, which is when you have a lot of data in particular, the LMs have challenges, and you have to be cautious. I do think, to your point, Nagam, that we do need to document the presence, or in my opinion, absence. I think if you look at how they work and the construct or the size and dimension of the data that are provided, you can infer what the expected performance will be based on how they work. And we'll see. Also, to your point, Pete, I think we're going to see evolution and iteration on the performance of these large language models as they get larger and smaller and more focused, more directed.
Fantastic. Let's thank Dr. Geoffrey one more time. Thanks, everyone.
I'm happy to stay a bit longer if people have questions more to continue the conversation.
And maybe are people online able to email you or reach out to you somehow, or?
Yeah, sure. It's Jeff, Geoff.
I hope that, got it.
It's that